right. All right, everybody. I'm just I had looked through what I had done the last time we met lecture-wise, which 2 weeks ago. So I figured I'd pick a spot where we could start. And there's several. I'm going to probably have to. I'm going to go through the Cowan PowerPoint on this, which encompasses effectively 2 units: this how things spread and how they do damage, and the epidemiological unit. And then I'm going to sort of track back and look at the Nestor stuff to make sure that everything was covered. You, you should have received the grades. I suspect you did, right? Yeah, I got that out this morning, and I didn't have my computer at home. I had my computer at home. I didn't bring my power cord, which is always a problem from the university. That's where all that stuff is. So, nevertheless, it just made my life easier. I just ignored school for a day, other than emails. And so I got that taken care of and sent the study guide. We still have the antibiotic unit to do. So there's what to do before so that's what I was thinking about when this would be. I guess it's early April, and then the final will be whenever the final is. So that concludes business. We have only 6 weeks to go. And I get to start it all over again right after. Like when you guys finish, even I think we start summer before even. And so anybody I'm doing micro in the summer for any of you who are doomed to repeat it, or just want to take it again for fun. Just oh, shut up! Nobody thinks you're funny. Nobody. They don't even like you. All right. So I thought this is kind of about where it left off, and really the incubation periods are interesting because a lot of times things are contagious early into an incubation period or before people become symptomatic. In the other PowerPoint sequence, they talk about a waterborne illness, which is a foodborne illness from either contaminated water or people who got sick, and spread it over multiple countries because it took 2 weeks for them, but while they were still somewhat contagious. So it's fairly significant. Okay, it's that lag time while it's getting busy replicating, doing whatever it's doing, bacteria or viral, and you're generating illness. So host resistance, virulence, et cetera, et cetera. So again, hours to years, but majority, I would agree, are in that type of thing. So we always have context these days. So it's probably several days. I would think typically if it was a fairly vigorous virus, depending on what mutation you were dealing with. The prodrome is when you start to notice it. You kind of, oh, something's coming on. And then the acute phase is when you're really sick. And that, yes, I agree. That's when you're most likely to be contagious. It's well established in you. There are not just you're feeling it, which are symptoms, as you recall, but signs where you can see tangible evidence, whether someone has a rash, whether somebody's throwing up, whether you can monitor them and they have a fever. You know what's going on there. And again, depending on all those other factors, how long it's going to last. So everything is like that are there. And depending, we sometimes we'll see chronic illnesses where people appear to get better, and all of a sudden it'll rear its ugly head. Like the infection will go away, and all of a sudden it didn't really go away. And I've seen too many instances of that. So, and now this is the so-called convalescent period when theoretically everybody's healing, returning, based on the immunological response. This is a very interesting side note for one of my points. It's all about, and for many of you going into nursing fields, this is the teaching point. This is what it's different now with healthcare, okay, because of the kind of health expenses that are covered. But for years, I can even imagine we doing it as a parent. Your little kid gets an ear infection, they give you that somewhat ubiquitous amoxicillin, the strawberry chewies, love those, or the liquid, which I prefer. And basically, you take it for 5 days. The kid takes it for 5 days to get better, and the parent goes, "I just put this in the cupboard," for the next time the kid gets sick, so I can save myself a doctor's visit. Whatever these days we think about the copay. The reality is that's the nugget that's there. Is you need you only remember the bacterial growth curve from way back. That's the thing that allows these organisms to develop resistance. So you need to take the appropriate antibiotic when we get to the antibiotic unit. The other one is you need to take it for the appropriate amount of time. That's one of the things that leads to that. And parents are parents, and money is money. And these are the kinds of things that entered. It's a little bit different today because of the nature of healthcare for the most. But having been there, seeing what it was like, how it's sort of morphed as I've been sort of paying attention to, let's say, over the last 50 or 60 years, you begin to see the changes that are there. So it's a really important teaching. These are the antibiotics. You take them. Okay. The only reason you stop taking them is when you get some type of a side effect that's remarkable. And most of the time, when you're talking about antibiotics or most agents, it's gastrointestinal. And if you're lucky, you can get somebody through maybe to the 8th or 9th day, and then you're probably out of jail with regard to that. Lots of those types of things. Okay, some in the so-called continuation phase lingers for long periods of time. You can even see some are symptomatic, some are not. It's an interesting kind of a thing, the so-called continue, and that's where we start to get into chronic illnesses that are there. A really important area of how we can control things is where we find them. It may surprise you having all the lockdowns and all that stuff associated with COVID. The easiest ones to control are ones that are theoretically just confined to us, because we can do what we did then. Whether or not I felt it was appropriate or not, or an over-the-top kind of a response, that's neither here nor there. The idea is we've been doing it forever. We've been quarantining. Okay? We basically restrict movement. We restrict people exposing themselves to other individuals, both when they're symptomatic or asymptomatic. They call it social distancing now. That was just a nice little catchphrase. But the reality is, it's kind of what we've been doing for a long time. So the reservoir, when it's with us, or the reservoir when it's with other members of the animal kingdom, to a certain extent, we can avoid them, okay, that are there. We can spray for mosquitoes. We can deal with animals in the wild to some extent, where we can at least have a certain amount of avoidance that's associated with them. That's just common sense. I mean, I remember when we talked about it with viruses. And I told you about it. I remember my daughter with all these little girls going, "Why don't you, go pet the chipmunks?" Well, chipmunks are rabid. Okay, it's not like I said. It's not Simon, Alvin, and Theodore. But I digress. Okay, so the primary habitat is really significant. Humans and animals, we have a little bit easier time controlling. Soil, water, and plants, particularly water, okay, much more difficult time controlling. So the transmitter, so-called an individual object who has it, okay, syphilis is strictly confined to humans. So the person or the individual or the entity transmitting it is the same where the reservoir is located. The reservoir is where it is located. Hepatitis A, the reservoir may be human, but we transmit it by contaminating the food. Remember, it's a fecal to oral virus. We expel the virus in feces, and it's one of those viruses that's very, very easy to, if you don't do adequate hand care, or if you're just feeling a little sick, you're still pretty contagious, those kinds of things. So you look at a lot of these. So animals other than humans and arthropods, these are different animals that are part of it. So arthropods, again, being insects. So we're a little bit more aware of those kinds of things. Bats transmitting rabies to humans. Bats are bad. Okay. Bats are a very interesting species that people like to study. But if you're going in and studying bats, you have to wear a lot of protective equipment. Their urine is extraordinarily toxic. They expel in urine and feces a lot of nasty stuff that's there. So can be transmitted to humans by vectors as fleas passing from the plague from rats to people. The flea is a vector. It gets an individual. So if you're thinking of plague, it's infecting the rats. As the rats die, The fleas are looking for another blood meal. So it's and so basically, if you that's where rat control sort of manifested itself. If you remember the old thing that we learned about in school called the Pied Piper of Hamelin, being able to rid the rats. I mean, so they've understood that rat control was, and even during the early days of plague, when they didn't understand it, they realized that there were problems associated with rats and things like that. So, and now when we look at vehicles such as water, leptospirosis, which is something we'll talk about a little bit in protozoan diseases transmitted from animal urine to human skin via bodies of water. And that's where people are bathing in contaminated water. And again, because our water supply is so pristine here, it's not something you and I think about, unless maybe if you're camping and you don't have a shower and you want to go. But it's not. It's more tropical areas than here, so I wouldn't be so worried about that. Obviously, with people who are actively ill, whether it is direct or indirect, and we'll get into that more specifically. A direct contamination would be you having a transmission of blood or body fluids from a close contact or an intimate contact, or something that was transfused inadvertently. Okay. Indirect means it typically has contacted a fomite, an inanimate object. Oh, here, can I use your phone? Mine just ran out of charge. Okay, that's an indirect contact if you want to think of it that way. A lot of times respiratory illnesses are less likely direct than indirect. So we're in a classroom. You guys weren't here a couple of years ago when we only had a maximum. In this classroom, we had 10 people. So everybody had, it was like every other chair, and they had little placards where you could sit. Okay. So the idea is you're roughly 6 feet apart. If you cough or sneeze, mask or not, some of those particles are going to get out. And they're only suspended in the air for a couple of minutes. So the only way you're going to get trouble by that is if it's right next to you. It's the way we're sitting now. So if someone's coughing or sneezing, yeah, then you could get it directly. But most of these are droplets, meaning they drop to the floor. So, or they drop on the tabletop. So, and they just have people coming in between classes, and students were coming in and cleaning things up, that type of thing. So that becomes indirect because they got an inanimate object, and maybe you reached down and touched your inanimate object, and it wasn't clean, and you touched your face. So that's the difference between direct and indirect. For a direct, particularly for respiratory, you have to be roughly within a 3-foot window for that to occur. Anything else that's going to drop to the floor, maybe it'll get, as people walk in, it might get kicked back up again. And there's a couple of things that are airborne: tuberculosis and the virus I talked to you about, the from rodent droppings. It'll come to me. Hantavirus. I thought I was done. I thought my mind was going. But I actually forgot something. I know. May 10th, 72. I should know it would be a difficult day because what's today? The date? Look on the phone. What does it say? 15th of March. The Ides of March are upon us. Julius Caesar. Don't go to the forum today. Didn't you have to read Shakespeare plays in school? Didn't they have like one every year? Like we did Merchant of Venice from freshman year. The teacher, what was her name? She was a typical old maid school teacher. Hair in the bun in the back. It's like a nurse with a cap on, like Nurse Ratched. And when we got to there's a very famous line in when Shylock is, so if they prick me, do I not bleed? Because it was more about really anti-Jewish sentiment that Shakespeare was writing about, because he was a Jewish lender, the Merchant of Venice. And she said, "Oh, when you say that, say if you nick me, do I not?" Understand that was a long time ago. It was like a long time ago, more than 50 years ago, considerably more than 50 years ago when that happened. So we did that to Julius Caesar, then we did Macbeth, and then senior year Hamlet, of course. Didn't you do stuff like that? Yes? Well, it was Cain. What do you expect?
You're right.
If you were not in rural northwestern Pennsylvania, didn't you do that in one of your schools? No. What's happened? I demand an inquiry. Okay. So, humans are carrier. We talked about that. Arthropods. Carriers can transmit a variety. So, you can read through this. Why am I reading it to you? It doesn't make any sense. So, humans have their reservoirs in other humans. So, the carrier is someone who has it, whether they're symptomatic or not. So, we have asymptomatic carriers. This is interesting. Okay. HPV and herpes, you can be a carrier and the lesion is not visibly apparent or noticeable to the individual. Gonorrhea is a little bit unusual for that. And that's kind of why gonorrhea periodically makes a comeback because normally it's very painful. Normally that's a very, very unpleasant and painful thing. And we'll get into that when we do, urinary tract / sexually transmitted infections. During the incubation, mono was such a big problem in close quarters that we see. And particularly that transition into the college environment, dormitory living, etc. Hepatitis A, convalescent carriers. That was one of the problems when we had that sort of that chi-chis type thing. Maybe that was a convalescent carrier. Chronic carriers, tuberculosis, typhoid, and again, sometimes that was the very famous typhoid Mary being an asymptomatic chronic carrier. Passive carriers. This is where you guys kind of fit in, most of you, who must constantly handle patient materials that are contaminated and the problem with accidental transfer. That's really one of sort of the underpinnings of a course like this. When you learn about, you have to be very wary of those contacts that were there. It's an interesting anecdote. Up in Butler Hospital, they had a very high infection rate, and they brought in an infectious disease specialist. And he's no longer there. I think he relocated to another state. I used to tutor before I started teaching. It was a good 20 plus years ago. When I was trying to get my teaching career, I was supplementing my income with tutoring. And his wife was also a physician. And he did something at Butler Hospital. He headed their infectious disease unit. He painted a line, had them come in and put a line in within X amount of distance from a bed. And anybody came over that line had to do hand care, which is one of the things they were not consistently doing. Somebody will drop off the tray, somebody do. If you crossed the line, you had to do hand care. The infection rate dropped by 50%. The Institute always, and the hardest thing, it's interesting, you generally didn't have to tell the person who was cleaning the room or dropping off the tray. They're afraid they're going to get sick. Doctors and nurses. That's who have, you're so busy that it's hard to not comply with the rules because you've got so many patients to see and so much stuff to do. It's hard. You're better for it, I think. And really, when you have leadership individuals do it. I remember I had a big argument with people when I was admitted back in 2006 when I was convalescing from having been in intensive care with salmonella infection. That the nurse, here's what the nurse, it's just not a knock on the nurse. This is the war between doctors and nurses. I came in because I didn't like the way that some of the nursing people who were taking care of me were not being cognizant of all the rules. Where I'm coming from an infection that put me in intensive care. And whoever the directors of nursing comes in, well, are the doctors doing that too? First question. Not my staff. What does that tell you? And I looked at her and I said, this isn't about the doctors right now. I'll answer your question, but let's address my concern first. Then we'll talk about the next concern. I was a patient they didn't want to have. So just saying, okay, animal reservoir agents are arthropods, fleas, mosquitoes, flies, and around here, everybody, ticks that are there. So there's a lot of these that are there. All mammals can get rabies. Birds, a variety of things that they conceivably could carry. But we really, the focus point for us, and there's some degree of either avoidance or control. Spraying for mosquitoes and other types of things. Being cognizant of where this is standing water. and things like that. If you're like, we had an above ground pool and the above ground pool started to fail, if you're not on top of that stuff and you start to get all that stuff on top, that's, if you're circulating, whether it's an above ground or an in ground pool, that, and you're not doing good care for that, that is a breeding ground. There's no question about that. Ticks have a lot to do mostly with where you reside. Unfortunately, we reside in tick central. Sorry, we just are, and there's certain kinds of diseases we'll get to with regard to those things. I have a non-contact policy with lizards. I don't bother them, and I don't expect. I have the same one with bears. I don't expect to bother, and snakes. Leave me alone. I'll, that has zoonotic origin, but it's jump species to be true. Yeah, and when they talk about zoonotic, I agree that that's the standard way of treatment. So we have infections and COVID, and now we're getting into this whole thing whether or not it was. I know a lot of people suspected this was a failure at the laboratory level that allowed this to go. I don't dispute that whatsoever, but that's the problem. When they analyzed it genetically, you saw fragments from different genetic species that were there. And that's, and as we look more closely when we get into respiratory diseases, and we're coming to this, once we get through antibiotics, then we're just going to deal with diseases. So indigenous to animals, typically, though I don't know that COVID would classify as that. I think it's sort of a blend, but naturally transmissible to humans. Multi-host, that's where the COVID thing is, just like influenza, multiple hosts. Some of the life cycles, when we get to see the complexity of some of these, when we talk about the most common one that we encounter here, Lyme disease, the number one vector-borne disease in the United States, Lyme disease, and potentially fatal. And it is fatal in some individuals if it's not addressed rapidly enough. And it's fatal in other species as well. Lyme is a big time problem, and we're, like I said, we're in Lyme disease central. Closest, well, it's, what can I tell you? I have a dog that's on top of me a lot. Okay, and 2 cats. Like this morning, if I don't pay attention to the cat for a significant amount of time before I leave, I am in trouble. He jumps up on the kitchen counter. It's like, pet me, or else I will not leave you alone. He's like that. And you may have heard me say, the cats rule. They're in charge. Okay. So obviously you're not going to do away with the animals if the cat is bothersome. So here are just some of a laundry list, and we are going to look, the ones that affect us, we're going to look at. We're going to look at rabies. We'll look a bit of yellow fever, certainly historically. Hanta, certainly influenza in West Nile. We don't see a lot of Rocky Mountain spot. We see more of it here than we do in the Rocky Mountains. Again, that has a lot to do with the ticks. It's a tick-borne disease. I don't know enough about psittacosis. Lepto isn't as common in this area. Anthrax, probably not so. Same thing with brucellosis. Certainly plague is very rare these days. Salmonella, not. Tularemia, yes. Okay. But, and then these other types of things that we'll come to as well. So they thrive, and that's really the problem in soil, water, and air. Okay. Surfaces otherwise. Most of them are really not problematic to us, other than those that we would consider to be opportunistic pathogens. An opportunistic pathogen takes advantage of someone or something, some living thing that its defenses are somewhat compromised. And compromised doesn't mean you have to be sick or have AIDS. Compromise can be a diabetic. Compromise can be someone with an active infection somewhere else. Compromise can be somebody who has some type of immunocompromise that isn't being dealt with appropriately. There's lots of things that make compromisers. So some are true pathogens, and there's always a possibility. We make the assumption every time we drink, we get water, that it's fine, that it's consumable. But there's a lot of instances, and I always kind of keep my eye open for websites and newspaper sites when I look for things that are recalled. in the background, I'm going, could we have any, particularly if it's something that we use, could we have any of this stuff? Because you have to be, I mean, it's coming from an area you're going to come contest with. The idea of being communicable, a disease which an infected host can transmit to another host. Okay, it's not necessarily interchangeable with infectious. Okay, communicable means the capability of spreading it. Okay, and I told you that anecdote about polio. What they began to shun people with polio because they thought it was, quote, catchy. Was the terminology we used to use. It is not. It came from the water. If you drank the same water as that individual, now you had a potential problem. So when we look at the terms of being contagious, it's the degree of communicability that's there. Some of these are extraordinarily, some are not. So they used to go wild. Oh, you remember all those biblical epics when, oh, they're lepers. I mean, leprechaun. They shunned those individuals. They put them in areas where they would basically just be amongst themselves. The reality was that a minimal contact was extraordinarily had to do with overcrowding. It had to be with there being long time. There was lots of different factors that made leprosy. But in biblical times, I would not have expected them to understand what was going on with those kinds of things. Versus influenza and measles are so easily spread respiratorily. They have a comparatively low infectious dose. They're easily communicable. So I understand that. I mean, where do you see the numbers? They're astounding. 95, 99% of all individuals prior to the MMR immunization got measles. Okay. When I was a kid, we all got it. This was an infectious disease that does not arise through transmission of the infectious agent from host to host. Okay. It could be your own microbes. That it's interesting. That doesn't preclude that necessarily being, if you had a wound that came from your own microbes, theoretically you might be able to change that. Accidental contact, okay, I can understand that. That exists in a non-living reservoir. You have an open cut, you go into some kind of, but even then, in the water or something like that, you might be able to get that. They don't become a source of the disease to others. To me, that would be more about non-communicable. So polio and tetanus, those are the kinds of things that are, because of the nature of what's going on, you're not going to be able to, unless they have the same type of things. For instance, if you see somebody with the shingles, okay, they can't give you the shingles, but they could give you the chicken pox if you did not have the immunity to it. So there's a lot of little subtle nuances to this. And then we get to the direct or indirect, which I was talking about before. So horizontal transmission, that's what we usually are concerned about. Our major concern are diseases spreading amongst us. Vertical, parent to child, that's a different type of a thing. So direct, close contact. Indirect, an object or a substance. Well, and again, the terminology that's used in science is a fomite, F-O-M-I-T-E, an inanimate object. A vector, okay, being something acting as a vector. Typically, when I talked about it with bacteriophage viruses acting as a vector, that was really acting as a vector. It wouldn't be truly considered a vector. A vector is typically another living agent, again, fleas, ticks, animals carrying rabies. Vertical transmission, transmitted from parent to offspring, either something that has been embedded in the egg or the sperm, acquired from the placenta, acquired by occupying the birth canal in a vaginal birth, or from lactated milk. So vertical transmission, that's the first one to look at. That's there. Very, very limited in what we see. It does not preclude that. So we utilize the idea, it doesn't have to be acquired, it's acquired in the birth process rather than being a byproduct of birth. So it doesn't have to be some illness that's there associated with the ovum or the sperm or in the milk. I mean, one where we probably see it the most, and certainly historically, was in the birth canal. And we'll get into those. That's where gonorrhea became such a monstrous problem. And today's untreated first herpetic infections of vaginal or genital herpes. Problem with regard to that. The one we think about, horizontal, direct, indirect, from an inanimate object or something else getting in the way, and then a variety of these vectors. There's a subtle difference between biological and mechanical vectors. If you think about, we talked about Reddy way back early in the course. He watched flies light on meat, and all of a sudden it started to grow. Basically, they lay eggs and grow larvae. Okay, what they were picking up were microbes. Okay, it's like if you think of a fly lighting on someone who didn't clean up after their dog, and that landing on your food, that's because it's on its little appendages. That's a mechanical vector. It's just carrying contamination from point A to point B. It doesn't interact with its life cycle. Lyme disease, okay, yellow fever, that virus or that bacteria is within the bloodstream of the vector, the flea, the tick, whatever it is. So it's a little bit different. So the insect injects the microbe into the host, so it's part of that microbial life cycle. Healthcare associated infections. The fancy name we give to these, you become intimately familiar with, if you're not already. There's 3 wonderful names. It's called nosocomial. He's acquired in the hospital. That's one of the things I was talking about the guy up in Butler. Nosocomial. You don't get paid. Hospitals, that impacts their bottom line. That's why it was such a buzz point when he was brought on board. Okay, because you're getting an infection that you did not have when you went into the hospital in a system that's unrelated to whatever you were being treated for. Big problem. Most of them come, interestingly enough, still catheterization. It's always been a big player. The number has improved. 40% of nosocomial infections used to be urinary tract, and you can read that as indwelling Foley catheters. You'll learn everything you don't want to learn if you're going into nursing about that. Just a ton. Nosocomial, hospital acquired or hospital induced, versus iatro, which means healergenic, means the doctor did it. Okay? So if I'm operating on somebody and they get an infection, that's an iatrogenic infection. I had a few of those. It does happen. Okay? Versus, I love this one, idiopathic. That does not mean an idiot did it, but sometimes it means we don't know. So there are idiopathic illnesses and idiopathic conditions that we don't know why they occur. And so we give that name when we can't find a cause. But HAIs, or nosocomials, acquired or developed during the hospital or a healthy care facility stay, and particularly in some other area. Okay, I mean, we understand if somebody had an operation and end up with pneumonia, which is not that unusual, that's probably not going to fall into it, though they're going to include it statistically. 0.1 to 20% of all admitted patients with an average of about 4%. That's still a big number, I think. 750, whenever this was written, let's say within the last 4 years when they crunched these numbers, nearly 750,000 cases, 75,000 deaths. That's very significant. Compromised hosts, areas where we find a lot of pathogens, where there's sick people, why we don't do as many procedures now, and why a lot of procedures are done on an outpatient basis. So-called, quote, clean procedures, a lot of doctors want to do in surgery centers, where they're typically going to be a same-day procedure, where they don't have to stay in the facility very long. I mean, it was the first time I operated on a patient with bone surgery, which I would now be exclusively, be a same-day procedure. They were admitted overnight. Okay, they had surgery the next day, and they were discharged either 1 or 2 days later. It's a 4-day stay, but healthcare and costs and finances did that. It's the first time I admitted somebody when I had hospital privileges was 1980. That, you know, it is what it is, 43 years ago. Dear God, I just need a drink. Where's the rest of your gang?
Oh, Olivia she got like post surgery.
Oh, really? She's entitled. You could have carried her in. Factors tied. Collection point, lowered defenses. Again, that's more about compromised hosts. Acquired directly or indirectly from fomites, equipment. That's the catheter aspect. Other patients, potentially. Medical personnel, surely. Visitors, why they ask you all those questions, why you're always wearing a mask. I just had one on yesterday because I had a doctor's visit over at the AGH in Wexford, etc., etc. Reusable instruments such as respirators and thermometers. Respirators, I think today we use more non-contact stuff and more disposable stuff than you would think of. The respirators, I don't know enough about. The catheters, number one in the hit parade. Heart valves, grafts, drainage tubes, etc. If you have an indwelling opening, which you're going to see a lot of ostomy sites, and there's a lot of care that's involved with those. You really have to know what you're doing with regard to that. A lot of antimicrobial therapy. A lot of people are on antibiotics and other antimicrobials. There's a lot of drug. The worst bugs are in the hospital. That's where they are. So when you start hearing about superbugs, and we're going to talk about that in the next chapter, the hospital is where they come from. And you're going to see a really interesting, they're called ESBL, extended spectrum beta lactamase, really inhibiting drugs that we're running out of their use. So we'll talk about that. So here they are. Most common ones: pneumonia, gastrointestinal illnesses, urinary, to me, still number one. Bloodstream, somewhat surgical site, certainly they're going to occur. So this is what you see, okay? The urinary tract infections, fortunately, that are catheter related are mostly from fecal contamination, because we see it in a lot of people, whether it's not being changed properly or whether or not they're incontinent also. So we do see a lot of, and what you have an abundance of, with incontinent people and fecal contamination, gram-negative rods. Okay, thankfully they're mostly gram-negative rods that are relatively easy to treat, like E. coli. Okay, like Klebsiella. Klebsiella different in the surgical side. The urinary tract not so bad. When we start getting Klebs pneumonia, big problem. C. diff. Everybody heard about that. That's related almost exclusively to broad spectrum antibiotics, which we'll get into at length. And the difficulty it manifests itself because of that. So, and the trouble is, once you have it, it's very difficult to get rid of without a relatively long course of antibiotics. And it's easy to spread because it's a diarrheal-based disease. Again, public enemy number one to me is still Staph aureus, surgical site infections, even pneumonia. Klebs, again, a fecal contaminant that you'll hear about. I used to have it here because it's a drug, it's a bacteria that we can acquire and test here in the laboratory. So it's not something to be frightened about. It's a normal content of feces that we all have. The trouble is, it has a very big capsule. And so if it somehow gets on somebody's hands and they touch their face and they inhale it, and they have respiratory problems, you get Klebsiella pneumonia, which is and oftentimes that's where some of these superbugs will come from. More than pneumonia, less so with surgical sites, much more treatable with urinary tract. Same thing here with E. coli. Enterococcus is another bear to treat because it's a common fecal contamination, gastrointestinal bacteria that unfortunately most of the time we find to be highly resistant. Something we'll talk about called VRE, vancomycin resistant enterococcus. And it's like ping pong between VRE and C. diff. You get rid of one, you get the other one. Use antibiotics to get rid of the VRE. Now the C. diff rears its ugly head. Put the C. diff antibiotics, the VRE comes back. It's awful. This is someone that any hospital will have, is typically someone in the nursing department. They're the infection control officer. They don't see patients, they track infections, all this stuff. Proper practices, training, looking at outbreaks, looking for any breaks in care, training, etc. Nurses and caregivers regularly exposed to all of these types of things. This is something, or any type of event has to be reported. Anytime there's an accident or an incident to report, particularly. There aren't that many of you here. For the guys who are here, and if you're going to nursing, my guess is you're concerned about this. Don't let anybody tell you not to write an incident report, particularly when you're new, because they think it'll look bad for them. That is your only defense against something adverse happening. If something happens, and all of a sudden they're not going to cover it if you can't work for a while, unless there's an incident report. That's ridiculous. Procedures are there to be followed. Follow them. If you may not necessarily win friends and influence people, but I mean, I think we have an expression that we use in medicine frequently, that when people in the know, it's called CYA. You cover your posterior. I would have said ass, but that's your tush, the back of the front, the fleshy part, the derriere, famed and song and story, permanent vertical smile. So all of these types of things. And so now you're seeing a lot more about universal precautions. Causative agents. This goes back to Koch. He was the first one to come up with this. It doesn't apply. His postulates were basically like a chain of evidence if you were watching a crime show. The standard for determining continue to play a role, reliable but not completely, because things don't spread that way. Koch was, and he saw it with anthrax. He got fluid from the sores on animals. He grew them in pure culture. Then he took samples of what was grown in the colonies in pure culture, injected in a susceptible animal. That animal died, and he was able, or got sick and eventually died. And he was able to reculture it and grow it again. The whole idea was growing in pure culture. That's one of the big problems with it. So now there's different postulates. They call them molecular postulates. Okay. Isolate, cultivate, characterize it, inoculate, not that you're going to inoculate people with it, and then re-isolate it secondarily. They frown on that. Okay, we can't grow them. Syphilis, number one on that break. We can find it, we can identify it, we can't grow it in laboratory. It's highly, highly fastidious. Okay, it's good news and bad news. The bad news is you can't grow it. The good news is things that you have an extraordinarily hard time to grow are very easy to kill. Okay. For forever, if you showed syphilis a picture of penicillin, it would die. No, please. Some infections cannot be elicited in animals. Viruses have it. So exactly. Sometimes you're testing, you may not get the infection. Viruses, again, the range is limited. Sometimes it's only humans. And polymicrobial diseases, there are many. Dental problems are frequently polymicrobial. Okay. So the question is, we go more into toxins. I reiterate this, okay? Toxic in small amounts, systemic effects sometimes. We'll look at all of these things, what they are. And so they're giving you this laundry list about concepts, but we'll get to those very, very shortly. And I think we went to that. So to me, in small amounts is a measure of infectious disease. The systemic effects is typically an endotoxin. Almost any toxin, typically an exotoxin, would be more so like botulism toxin or tetanus toxin. Released by shells, by shedding, or during lysis. Again, that probably applies more to an endotoxin. Small proteins, definitely an exotoxin. Lipopolysaccharide, definitely an endotoxin, can be converted to a toxoid exotoxin. Exotoxins, basically proteins, typically small chains of amino acids. They're relatively easy to create toxoids of. They're typically very, very toxic, where endotoxins are lipopolysaccharide based, generally occur when the cell bursts apart. E. coli, the aforementioned salmonella, and they're much more systemic. They both can be systemic, but these, fever and inflammation, probably apply to both, I would think. And now we're going to look at epidemiology, important about notifiable and reportable. I do a whole thing about that are there. And then the terminology that's there. I mean, we went crazy, just to summarize it briefly, because I probably won't have time to start this today, about we are in a pandemic. Oh my God. The world's, it is not. I mean, if you want to make a case, HIV is still pandemic. We haven't died from it. We know how it's spread. We have a lot of information. We have ways to treat it. It wasn't something that was going to destroy the world. Really, it wasn't. Okay? I mean, surely there are other viruses that are pandemic in nature. What does pandemic mean? It means it started with an epidemic. An epidemic is a statistical increase of cases over the expected number of cases. That's when something reaches epidemic proportion. Endemic is something that's always part of us. The common cold's always with us. Measles is with us. We just don't know it because most people are immunized. So an epidemic is like that. If that epidemic, for whatever reason, typically worldwide travel, sometimes shipping lanes, different things along those lines, okay, crosses a continent, typically crosses a major body of water like an ocean now, and it establishes itself in epidemic proportion in another continent. Now it's a pandemic. That's what it is. So, I mean, we didn't lock down after the common cold pandemic. And hopefully they don't do that again, because we're still trying to reach out from economically from that. Don't call me crazy. So epidemiology, we're going to look at that. I have a whole PowerPoint sequence to go with. Notifiable and reportable are so important. It's all about legal obligations. I've said this 1,000 times. I'll say it once more. Licenses are very hard to obtain and very easy to lose. So a notifiable reportable illness is something you are obligated to report to whoever does the reporting. If it's you, report it to the health department. If it's your supervisor, note that. Inform my supervisor this was a positive test for blank. Put it someplace where it's documented. Take a snap picture. Again, CYA. Because whether they report it or not, that's up to them. Okay. I mean, theoretically, you're going to see a list of diseases. Not everybody's reporting them. Some of you don't have to anymore. Why? They're out of control. HPV, horrible, contagious. Don't have to report it. Why? Because we can't control it. We're past the stage where we can intervene and limit its effect. I'll leave it with that. What fun we're having. Well, it's been real. Nice seeing all you people out there in virtual land. Have fun. Goodbye.